Hi, I'm Dr. Monica Gandhi, Associate Division Chief of the Division of HIV, Infectious Disease and Global Medicine at UCSF San Francisco General. And joining me today is Dr. Lucy Horton. Thanks for being here.
Thanks so much for having me.
Dr. Horton is an assistant professor of medicine and infectious disease doctor at UC San Diego Health. And today we'll be discussing real-world use of anti-SARS-CoV-2 monoclonal antibodies. So which patients specifically are eligible for an anti-SARS-CoV-2 monoclonal antibody for either treatment or pre-exposure prophylaxis? So in terms of treatment, really BEB at this point as the one that's going to be most active against BA.2.12.1. These are really patients who have mild to moderate COVID-19 who are at high risk of progressing to severe COVID-19. These monoclonal antibodies are only approved for 12 years and up, and the risk factors for progressing to severe disease are the traditional risk factors even without vaccination, which are age over 65, being overweight or having obesity, having diabetes, chronic kidney disease, chronic lung diseases, being immunosuppressed, chronic kidney diseases, pregnancy, sickle cell anemia, or other disorders of neurodevelopment. Now, in terms of pre-exposure prophylaxis, that is a different modality. That is really giving ticks and SIL as a combination monoclonal antibody to protect those who are severely immunosuppressed for about 6 months. There's an 82% protection of getting COVID-19 at all, even with the BA.2 variant and subvariants. But that's really for our profoundly immunosuppressed populations. So, Dr. Horton, I would ask you here is what steps and staffing are necessary for patients to receive an anti-SARS-CoV-2 monoclonal antibody? Your center in particular has really worked hard on the logistics of getting patients the therapies they need.
So I think what we need is really a centralized system that can rapidly assess patients, determine if they're eligible, and then coordinate their monoclonal antibody treatment. So first, kind of focusing just on treatment for mild to moderate SARS-CoV-2. At our center, we have a team in place who reviews all the positive results, and they will help determine if a patient meets the criteria for one of the treatments. They then coordinate to see the patient for a video visit, consent the patient, and then pretty much in real time coordinate with the infusion center to have the patient seen later that day for the infusion. It's important also to have, a place where this can be done safely. These are patients who have acute COVID, and therefore, it's a higher risk setting. And in our infusion center, we have a separate area for these patients. Now for prevention, it's a little bit different. We have a little bit more of the luxury of time. We don't need the patient to come in the same day. But at the same time, we would prefer that they receive the treatment sooner rather than later. We actually have developed kind of an off-site, almost like a drive-through center for the prevention. And it's done outside in open air. Patients are monitored after they receive the injection. But again, it's really a lot of staff that's required. It can be really resource intense, both to do the monoclonal antibodies for treatment and for prevention.
So I do think that your center and mine both, and I'm at San Francisco General, so serving a publicly insured population, have really focused on the need to treat COVID-19 among racial and ethnic minorities. This has been an infection, COVID-19, in the United States that has disproportionately infected and unfortunately caused hospitalizations and deaths among those of racial and ethnic minority status. So this was and continues to be an incredibly important population, treating racial and ethnic minorities, those who are marginally housed, those who have disparate outcomes, to really prioritize them, not just for monoclonal antibody therapies, but importantly for the oral antivirals, where we're already beginning to see disproportionate access to the antiviral therapies to those who have means and those who advocate for them. And I know what we're doing at our center, which is because we really do only serve publicly insured patients. We are being very active about identifying those at risk for severe breakthrough, getting the pre-purchased doses of Paxlovid and molnupiravir by the government into our center, keeping ourselves informed about, do we have the right number of doses, do we need more, and being really proactive in offering these antivirals and monoclonal antibodies as needed. I'd be interested in your best practices for overcoming disparities in care, Dr. Horton.
Thank you. Yeah, I think you really highlighted a lot of the challenges that we are facing getting these patients treated and getting them monoclonal antibodies for prevention as well. And I think oftentimes it starts with identifying that they even have COVID. So making sure that we're offering testing and follow-up care to everybody, regardless of their insurance status, for example, is really important. And then finding ways to overcome some of the barriers that they face in having the physician visit or coming into the infusion center. So things like transportation is really important. Offering information that is culturally and linguistically available to a lot of patients. It can be a bit overwhelming to learn about a new treatment. And so being able to offer patients, resources in their own language and at an appropriate reading level, I think is really important as well. It remains a really big challenge and one that I know we're actively working to address here in San Diego.
So thank you so much for joining me today, Dr. Horton.
Thank you.
And for more information on anti-SARS-CoV-2 monoclonal antibodies for treatment or pre-exposure prophylaxis, please visit the series landing page at exchangecme.com. And for the latest updates on COVID-19, subscribe to Exchange CME's YouTube channel and check back regularly. Thank you.